Hey, as people start to join, I just want to welcome everyone. We are so excited to have you here today for our lecture, Treatment and Prevention of Syphilis in People with HIV. I do want to encourage folks to go ahead and please complete the demographic questions. You should see the poll pop up on your screen. So please take a moment and do that for us as folks are starting to join. All right, and I see the number of participants still climbing just a little bit. If you didn't hear me already, I just want to welcome you to our webinar today and also encourage you to please complete the demographic questions that should have popped up on your screen. We'll give folks just another minute or so to get those completed. All right, so I'm seeing responses pop up. And still a few more joining, but I think we're starting to settle out. So my name is Meredith Clement. I am an associate professor at Louisiana State University Health Sciences Center in New Orleans. Our presenter today is Dr. Khalil Ghanem, who is at Johns Hopkins University in Baltimore. And our webinar today is Treatment and Prevention of Syphilis in People with HIV. Again, welcome everyone. We're so excited to have you join us today. All right, and just we'll breeze through these slides, but these are financial relationships with ineligible companies in the last 2 years. Again, financial relationships. Here is information on CME. And here is the CME points and categories that you guys are eligible for completing this activity. We want to extend a special thanks to our supporters today, Gilead, Merck, and ViiV. And then just a final reminder, please do not submit questions to the chat. We want you to submit questions to the Q&A, and we will have designated time at the end of Dr. Ghanem's talk for some questions and answers. And then I guess without further ado, I'd like to welcome syphilologist extraordinaire, Dr. Khalil Ghanem. Take it away, Dr. Ghanem.
Thank you, Dr. Clement. Thank you so much, everyone, for joining. What a nice crowd. So today we're going to be talking about syphilis. First, I'm going to share my screen just to make sure I can share the screen. There we go. Hopefully you can see my slides now. And we're going to have fun. That's the goal of this session, is to have fun. And at the end of it, I'm hoping that you will feel much more comfortable managing syphilis. Now, I'm going to tell you a secret. I'm going to focus a lot on the management of serologies, because a lot of people really struggle with serological titers. What do I do with this titer? How do I interpret this serological test? And we're going to talk a little bit about neurosyphilis and ocular syphilis, and we're going to talk about some questions that come up. Do I need to give extra doses of benzathine penicillin G when I treat for neurosyphilis? Should I be using steroids when I'm treating for ocular syphilis? All of those we're going to cover, and hopefully it'll be fun because it is a patient-based discussion. We're going to have 2 patients. We're going to talk about them. Both patients are real patients that I saw, and so hopefully you will find this useful. I have no relationship. We talked about the objectives, and we're going to start with some questions, all right? 2 questions, pretest questions, Here we go. A 32-year-old cisgender asymptomatic man, newly diagnosed with HIV, is screened for syphilis using the reverse sequence algorithm. So we start with a treponemal test, and then we do the RPR. The results revealed a reactive treponemal EIA, a non-reactive RPR, and a reactive treponema pallidum particle agglutination, or TPPA. So two different treponemal antibodies that are reactive. The RPR is not reactive. Which of the following interpretations of the serological tests does not apply to this patient, assuming you don't know anything about this patient? Could it be early syphilis? Could it be a false positive treponemal antibody response? Could it be treated syphilis? Could it be old untreated syphilis? Which one is not likely? Not likely. Unlikely. So I know it's the negative. Keep that in mind. All right. So I will give you 10 seconds. We should have the Jeopardy theme. All right. Okay, my friends. Okay. So some people said it's not early syphilis. Some people, so it's a little bit of a distribution. And then most people said B, false positive treponemal antibodies. We're going to go over that question again at the end. And I know that 99.9% are going to get it right. So that's the first question. All right, the second question. A 40-year-old man with HIV was diagnosed with early syphilis 1 year earlier and treated with 2.4 million units of benzathine penicillin G. His pre-treatment RPR at the time of diagnosis and on the day of treatment was 1 to 32. His titer was still at 1 to 32 3 months later, 1 to 32 at 6 months, and 1 to 16 at 12 months. The patient is asymptomatic, and he denies the possibility of reinfection as he has been celibate since his diagnosis 1 year ago. His physical exam is completely normal. Which of the following is the most appropriate next step in the management of this patient? Continue to monitor the titers, do a lumbar puncture, a CSF exam, another 2.4 million units of benzathine penicillin G, or 3 doses of 2.4 million units of benzathine penicillin G, each dose 1 week apart. So essentially, you're treating him for latent syphilis. Which of the following do you think is the best approach given this history? All right. Let's see what you guys are going to say. Or maybe I won't see. I don't know. Think about it. We're going to cover it in just a few minutes. All right. I think I'm going to keep going so that we don't waste time because we have a lot to cover, my friends. All right. Here we go. So our first patient, remember 2 patients for this entire seminar, webinar. So the first patient is a 32-year-old man with HIV. CD4 count is 750 and HIV RNA undetectable on Biktarvy. He presents with, now be careful, headache, photophobia, and tinnitus in both ears for the past 2 days. He denies any other symptoms. He was diagnosed with HIV in 2018, started on ART, and has done very well. He's not had any history of opportunistic infections. In the prior 18 months, he was diagnosed with pharyngeal gonorrhea and rectal chlamydia, and both times he was treated appropriately. Social history, he reports 3 male sexual partners in the prior year, including a new sexual partner in the last month. He drinks 2 mixed drinks a week and does not endorse any other drug use. Medications, again, just the Biktarvy. And these are his physical exam findings. He has a 1 by 1.5 centimeter ulcer on his tongue. It is not painful, and he had no idea that he had it. He does endorse photophobia, and he does demonstrate some neck stiffness, but no other ocular abnormalities. He had a full ophtho exam, nothing else. Normal GU and rectal examinations, normal cranial nerve, motor, and sensory exam, but he did self-report tinnitus. The testing results show a normal comprehensive metabolic panel and CBC. His syphilis EIA is reactive, RPR is non-reactive, and TPPA is reactive. CT of the head was unremarkable, and all the other STI testing was negative. So his EIA is reactive, TPPA is reactive, so his 2 treponemal tests are reactive, but the RPR is not reactive. What's going on, right? I mean, why is his darned RPR not reactive? So what are the rules when interpreting serological tests? Listen, if you remember these rules, you will interpret any serological test that's handed to you, assuming you know one additional thing in addition to the rules: the patient history. Never, ever try to interpret serological tests for syphilis without knowing the patient history. If you don't know the patient history, you're likely going to get it wrong when you try to interpret serological tests. So if you send me an email and say, I want your advice on this patient, and you send me their titers, send me their history with each of the titer. Could they have been reinfected at that time? Were they abstinent at that time? What was going on? If I know what's going on with the patient, we can give the right suggestions for you to do. But if I don't know the history at all, I just don't know what to tell you about these titers. So be mindful that in order to interpret titers well, and if it's one thing you take out of this webinar, keep in mind, you need to know the rules on how to interpret titers, and you need to know the patient history. If you know both, you're golden. You're going to be able to interpret and do the right thing for your patient. So what are the rules? Here are the rules. They're very easy. Let's start with the RPR, okay? So the RPR are the non-treponemal tests. Remember, the RPRs can be non-reactive in 30% of persons with early primary syphilis. Our patient had an ulcer on his tongue. He didn't have any manifestations of secondary syphilis. Most likely he had primary syphilis. Could the RPR just not had time, the antibodies not had time to be produced? Keep that in mind. The other reason to have false negative RPR in the setting of syphilis is a prozone reaction. And usually the prozone reaction is seen during secondary syphilis. The organisms are going crazy. The amount of antigen is huge. The amount of antibody is less. And because there's discrepancy between antigen concentration and antibody concentration, you get a false negative RPR. If you call the lab and say, hey, can you dilute the specimen? They will dilute it, and suddenly the RPR comes back reactive at 1 to 512. So keep in mind the 2 reasons for a false negative RPR are early primary syphilis and the prozone reaction. Otherwise, if the RPR is negative and it's not a false negative, they may not have syphilis, or we're going to follow that up with the second 2 rules. False positives occur with the RPR commonly, and the most common causes of false positives are older age, autoimmune diseases, HIV and other infections, cancer. Many things can give you a false positive RPR. So if you have just a positive RPR, you don't know if it's from syphilis or if it's due to something else. What do? You get a treponemal test. The treponemal test, the only reason for their existence is to confirm that a reactive RPR is essentially a true positive RPR. Okay, so that's the main reason for the treponemal test. So we can get false negative RPRs, we can get false positive RPRs, and then the third rule is the one that you have to keep in mind. The RPR may become non-reactive with or without treatment. So you can treat somebody for syphilis, and over the next couple of years, the RPR can become non-reactive. Excellent, you all knew that. But keep in mind that you can have somebody who gets infected with syphilis, and 3 to 5 years later, even if they are not treated, their RPR can become non-reactive. So now we know the RPR. What are the possible causes of a negative RPR? One, the patient doesn't have syphilis. Two, the patient has early primary syphilis. Three, the patient has secondary syphilis and has a prozone reaction. Four, the patient has old treated syphilis or has treated syphilis. And the last possibility, old untreated syphilis. Old untreated, old treated, not syphilis, false negative because it's early syphilis, false negative because it's a prozone reaction in secondary syphilis. Those are the possibilities with a negative RPR. And so now you know the three rules related to the RPRs. What about the three rules related to the treponemal antibodies? All other tests, EIA, CIA, TPPA, FDA, they're all treponemal antibodies. These are the three rules. Again, the first rule is the same as the RPR. They can be negative in somebody that has early primary syphilis because the body just hasn't had time to make antibodies. Now, there are situations when the treponemal antibodies are produced before the non-treponemal antibodies are produced. And maybe that's what's going on with our patient, right? The treponemal antibodies became reactive, but the RPR antibodies still haven't become reactive. That's possible. So false negatives, treponemal antibodies in early primary syphilis, just like the RPR. Second, you can't have false positives. They're less likely than with the RPR. The RPR, there are many causes of a false positive. But with treponemal antibodies, there are a few. One of them is Lyme disease. The other one is gingivitis, because we have a lot of treponemes in our mouths, and gingivitis can give us a false positive treponemal antibody test. That's why when you get a treponemal antibody test that's reactive and the RPR is non-reactive, you always get a second treponemal antibody to make sure that the reactive first treponemal antibody is a true positive and not a false positive. So if the second treponemal antibody is positive, now you have the first treponemal antibody that's positive, the second treponemal antibody that's positive, then you know the patient definitely had or has syphilis, and it's not a false positive. One treponemal antibody test that's positive with a negative RPR could be a false positive treponemal antibody test. But two different treponemal antibodies that are positive, it is not considered a false positive treponemal antibody test. So keep that in mind with our pretest question number one. And then with the treponemal antibodies, once reactive, always reactive. So whenever they're reactive, they're going to stay reactive, even if you treat the patient, etc. So that's the big difference between non-treponemal and treponemal. The non-treponemal, they can become non-reactive with or without treatment. The treponemal, they will always stay reactive. Now that you know these rules, right? Now that you know these rules, you can interpret any permutation of these serological tests. And you have labs that begin with screening testing using the RPR, great. And you have labs that begin with the reverse sequence algorithm, starting with a treponemal antibody test. Great, it doesn't matter. If you know these rules and you know the patient history, you can interpret any permutation. So with our patient who has two reactive treponemal antibodies, and they're two different ones, right? So we know it's not a false positive treponemal antibody. So we know that the patient either had syphilis or has syphilis. Those are the two treponemal. The RPR is non-reactive. Ooh, the RPR is non-reactive. So it could be, old treated syphilis. It could be old untreated syphilis. But wait a minute, it could also be, the patient doesn't have secondary syphilis, so it's not a prozone. We know that the patient has syphilis, so it's not, the patient doesn't have syphilis. The patient has syphilis. So it's not old treated, it's not old untreated. But the third possibility is he could have early primary syphilis, the ulcer on his tongue, and he just had antibodies against the treponemes made before the RPR antibodies are made. Sometimes you can see the treponemal antibodies becoming reactive before the RPR. See, you know the rules, you applied the rules, and you were able to interpret the tests based on the history. If you didn't see that ulcer, you wouldn't know that the patient had primary syphilis. And so then it becomes more difficult to figure out why the RPR is non-reactive. So you see how important it is to have the history and to know the rules of these serologies. Now, remember, you do have direct diagnostics. You can do a dark field on a genital lesion, but you can't do a dark field on an oral lesion because our mouth is full of treponemes that are not syphilis, like Treponema denticola. So you cannot do a dark field microscopy on that oral ulcer because you're going to get a false positive result from the oral treponemes. You can definitely do a PCR from the oral ulcer. They're not FDA cleared, but they are available at large commercial laboratories. So the direct diagnostics, it's either dark field microscopy or it's the PCR. If you have access to a PCR, it works very well for early lesions, primary and even some secondary lesions. But it does not work well for latent, and it does not work well for neurosyphilis. Now, there are a couple of point-of-care tests in the United States that are FDA cleared. They identify Treponema pallidum antibodies, specific antibodies, right? They are looking for that antibody to T. pallidum, treponemal specific antibodies, and these two are listed here. They work fine, but keep in mind that without the RPR, right? Keep in mind that without the RPR titer, it becomes more difficult to manage patients. So if you do a point of care test and it comes back reactive for a treponemal antibody, what are the possibilities? One, it's a false positive treponemal antibody test. Or two, it could be a true syphilis, and it could be old treated, old untreated, new. You don't know. It's syphilis of some sort if it's not a false positive. How do you figure it out? Well, first you get a history from the patient. Have you ever had syphilis before? Yes, and I was treated. Okay, well, it could be positive from the time that that patient had syphilis before, or they could have been reinfected. Without the RPR, you cannot manage the patient appropriately. If somebody gets a point of care test and it's positive for treponemal antibodies, and the patient says, I've never had syphilis before, great. Likely, if they have a pretest probability that they could have been infected, let's say somebody who has sex partners and they're not using condoms, and the positive treponemal antibody and no prior history of syphilis, then you say, you know what? Most likely they're infected. I'm going to send an RPR to the lab. That way I have a baseline RPR on the day of treatment. And then I'm going to go ahead and treat the patient immediately. That's fine, as long as you have a baseline RPR. Otherwise, it becomes very difficult to manage the patient. So what is your diagnosis for our patient? So our patient essentially has tinnitus, headache, photophobia, but no ocular abnormalities. So most likely our patient got infected with syphilis, right? And then developed the primary lesion of syphilis in his mouth. But remember, 50+% of patients, the organism has already invaded the central nervous system even before the patient develops any lesions. And so this patient, based on the history, most likely has early syphilis, probably early primary syphilis, with evidence of otic syphilis and probably neurosyphilis, given the headache, the new onset headache, and the neck stiffness and the photophobia. Classic presentations of early syphilitic meningitis and otic syphilis with bilateral tinnitus. So all of this is happening very early after infection, and it can happen anytime. So questions to ask all patients. Whenever you see a patient with syphilis, you should always ask questions related to neurosyphilis, ocular syphilis, and otic syphilis to make sure that you're not missing it, because they can take place. These sequelae can occur during any stage of the infection. So have you experienced recent or different headaches? Somebody who's had 20 years of headaches and they're not changed, that's probably not neurosyphilis. But have the headaches changed? Or they never had headaches and now they're having headaches. Photophobia, neck stiffness, weakness, new seizures. Have you experienced difficulties with gait or memory? Do you feel or were you told that your personality has changed? With ocular syphilis, have you experienced recent blurry or loss of vision, pain or redness in the eyes? Do you see floaters or flashing lights? With otic syphilis, new onset hearing loss, tinnitus, vertigo. If you see an elderly patient who's had hearing loss for the last 30 years, probably not otic syphilis, right? But somebody who's had new onset hearing loss or sudden worsening hearing loss, vertigo, tinnitus, or ringing in the ears. Most of these clinical manifestations are not specific for syphilis, but the art of medicine comes in where you talk to the patient and say, okay, tell me about these headaches. Have you had these headaches before? Oh yeah, I've had them for the last 10 years. Okay, not neurosyphilis. No, I've never had these headaches before. These are new. Or you know what? I have headaches, but these are very different from the headaches that I have. Could be neurosyphilis. All right. So you have to ask questions and then you have to interpret it with the patient being there to understand whether you think this is due to neurosyphilis or ocular syphilis or otic syphilis or due to something different. Keep in mind the following. If you suspect ocular or otosyphilis, you do not need a lumbar puncture to make the diagnosis. If you suspect neurosyphilis, you need a lumbar puncture because a negative lumbar puncture for neurosyphilis rules out the diagnosis of neurosyphilis. But a negative or normal lumbar puncture does not rule out ocular or otic syphilis. You can have ocular syphilis and have a normal lumbar puncture. You can have otic syphilis and have a completely normal lumbar puncture. And so for ocular and otosyphilis, you do not need to have a lumbar puncture to make the diagnosis of ocular or otic syphilis. For neurosyphilis, you need to have a lumbar puncture. So when you see a patient, I see this happening all the time. You see a patient, you say, ooh, this patient has ocular signs and symptoms. I'm concerned about ocular syphilis. You send the patient to the emergency room. Often what happens in the emergency room, somebody will do a lumbar puncture. It's normal. They send the patient home. Don't let that happen. If you suspect ocular or otic syphilis, send the patient immediately to the emergency room. Don't wait if you suspect those two diagnoses. Call the ED physician and say, listen, I'm sending you somebody with ocular syphilis. Have them evaluated by an ophthalmologist. And if there are abnormalities on ophthalmologic exam, you don't need to do a lumbar puncture. Just start them on 10 days of IV penicillin. So you don't want these patients to fall through the cracks. Otosyphilis, ocular syphilis, neurosyphilis. They're all treated with 10 days of IV penicillin, but with neurosyphilis, the lumbar puncture can help you rule out the diagnosis. Otosyphilis and ocular syphilis, it doesn't. Now, what do you do with patients like our patient, the one we just talked about right now? Headache, photophobia, neck stiffness, neurosyphilis, and tinnitus, otic syphilis. He has both neurosyphilis manifestations and otic syphilis manifestations. So would you perform a lumbar puncture? And the answer is complicated here because if he only had tinnitus, no. If he only had eye manifestations, no. But he also has headache and photophobia, and that's meningitis. And remember, there are many things other than syphilis that can cause meningitis. In my opinion, and there's disagreement out there, but in my opinion, I would do a lumbar puncture, not because it's going to change management. Even if the lumbar puncture is normal, that patient is going to get 10 days of IV penicillin for the tinnitus. But what if I find another reason for the patient to also have meningitis, another organism? I wouldn't want to miss that. And so what I recommend for clinicians, a patient with both neurological signs and symptoms and ocular or otic signs and symptoms may benefit from a CSF exam. It's not going to impact the treatment decision, but it may impact the diagnostic decision. What does the patient have? And so I usually, whenever there are neurological signs or symptoms, I always do a lumbar puncture. If it's only otic or ocular, I don't do a lumbar. So our patient had a lumbar puncture and had abnormalities. The CSF VDRL was non-reactive, but the white cells were, he had pleocytosis, and they were all lymphocytes. The protein was normal, and everything else was pending. And so, what is your diagnosis? Well, he clearly has CNS inflammation, most likely secondary to neurosyphilis. So he has neurosyphilis. The tinnitus, he has most likely otic syphilis, and he has this ulcer on his mouth, so he has primary syphilis. So he has all of these clinical manifestations. How do you diagnose neurosyphilis? Well, the two tests that I immediately look at are the CSF VDRL and the pleocytosis. The CSF VDRL is very specific. If it is reactive in the CSF, in the absence of gross bloody contamination of the CSF. So if there aren't that many red cells in the CSF and the CSF VDRL is reactive, they have neurosyphilis. The other test, but the problem with the CSF VDRL, in 50% of patients who have neurosyphilis, the CSF VDRL is non-reactive. So it is not sensitive, but it's very specific. Pleocytosis, CSF pleocytosis, I can't remember the last time I've seen a patient with neurosyphilis who didn't have an elevated white cell count in their CSF. It's very sensitive, but so many things can cause CSF pleocytosis that it's not very specific. And so you have to use the combination of the testing that you get and pretest probability. Does it make sense that the patient should have neurosyphilis? Signs, symptoms, serological tests. If everything makes sense, then you can make the diagnosis of neurosyphilis. What about the protein? A slight elevation in protein. It's always the slight elevation in protein and nothing else is abnormal. I don't call it neurosyphilis. If the protein is very high, I'll think about it. But protein is not specific and not sensitive. And so using the protein alone, unless it's very high, I usually ignore it if it's only slightly elevated. I want to see white cells. The white cells are very sensitive. The CSF VDRL is very specific. So how do we treat this patient? They have neurosyphilis, ocular syphilis. They have neurosyphilis, otic syphilis, and early syphilis. How should we treat this patient? Well, for early syphilis, if they didn't have anything else, 2.4 million units of benzathine penicillin G. And now the good news is benzathine penicillin G is available again on the market. Hurrah. So 2.4 million units of benzathine penicillin G if they didn't have any neurological or otic manifestation. That's for early syphilis. 3 doses of 2.4 million units for late latent syphilis or syphilis of unknown duration, when the patient is asymptomatic and you don't know how long they've been infected. But our patient has neurosyphilis and otic syphilis. And so we have to treat our patient with essentially 10 days of IV penicillin. And if you absolutely can't use IV penicillin, you can use 10 days of IV ceftriaxone. But penicillin is the drug of choice to treat neurosyphilis, ocular syphilis, and otic syphilis. So 10 days of penicillin is going to cover neurosyphilis, ocular syphilis, and otic syphilis, and it will cover his early syphilis too. So 10 days of IV penicillin for our patient. Should we use steroids to treat otic or ocular syphilis? And the answer is nobody knows. Nobody knows. There are no data. You can if you want to. So what I usually tell people is, if there is no absolute contraindication to use steroids, for example, if the patient is a brittle diabetic, don't use steroids. But if there are no absolute contraindications and the ophthalmologist or the ENT doctor is very enthusiastic about using steroids, go ahead and use steroids. It's not going to harm, but we don't know if it's going to provide any benefit. We just don't know. And so I have no problems if there are no contraindications. But keep in mind one thing. How should I use them? If you treat for a short period of time, meaning less than 10 to 14 days of steroids, if you treat for a short period of time, and usually the dose is somewhere around 40 milligrams of prednisone, and you can taper it down slowly. If you treat for a short period of time, patients, once you stop the steroids, can have worsening of their symptoms. Don't freak out if that happens. just put them back on the steroids for a few more days. They're not failing therapy. The minute you stop the steroids, if you use too short courses, like if it's less than 7 days of steroids, your patients may worsen when you stop the steroids. If they do, don't panic. Just put them back on the steroids for a few more days, and it usually goes away. So, excuse me, that's the story with steroids. We don't know if you're going to use them for at least 10 days, I would say, sometimes as long as 14 days. Occasionally, I've had patients get worse, even after I stop at 10 days. So I've extended it to about 14 days. And most patients do just fine in that setting. If you don't want to use the steroids, don't use them. I don't use them unless the ophthalmologist said, oh, but you have to. And then I say, okay, listen, there are no contraindications. Have at it. We can use steroids. And I talk to the patient. I warn the patient about the toxicities of steroids, and we move forward. The other huge question, you guys submitted some questions right before this webinar. And the most common question that I read was, after I treat somebody with for neurosyphilis with IV penicillin or otic syphilis or ocular syphilis, and if they have late syphilis, late ocular, late neuro, late otic, should I use additional doses of benzathine penicillin GIM at the end of the IV treatment? The guidelines suggest that you might consider it. But let me tell you what, I don't. And I've told most of the folks that do neurosyphilis work, Christina Mara, Sheila Lukehart, Ned Hook, and none of us use any additional doses of benzathine penicillin G. I give 10 days of IV penicillin for neurosyphilis, ocular syphilis, and otic syphilis, and then I stop. The ASDDA is going to come out with a statement that essentially dissuades people from using additional doses of benzathine penicillin G. And the reason is nobody knows what the optimal duration is of late latent syphilis. And when somebody has ocular, otic, and neurosyphilis, they don't have late latent syphilis. They have tertiary syphilis. And it is likely that the organism is replicating faster. So you don't need to use these long doses. And so adding additional doses of benzathine penicillin G is not based on any clinical data, and it is not based on any experimental animal model data, none. And so I recommend that you not do it. If you want to do it, if it makes you feel better, fine. Give 1 additional dose of benzathine penicillin G at the end of 10 days, and you're going to be just fine. There is no reason to give a full 3 doses of benzathine penicillin G. So 1 additional dose if you can't sleep at night. Otherwise, I sleep just fine. I give 10 days of IV, and I call it a day. Now, we've diagnosed this patient with neurosyphilis. Do we need to repeat the LP in 6 months? And the answer is no, because our patient, hopefully, the CSF, the clinical findings are getting better. The RPR titers in the blood are getting better. And the patient was on antiretroviral therapy at the time of neurosyphilis diagnosis. And so if all of these things are true, you do not need to repeat the LP 6 months later. In patients who are not on antiretroviral therapy, at the time of diagnosis of neurosyphilis, the recommendation is to repeat the LP 6 months later. But in patients who are immunocompetent, or if they're living with HIV and they are on antiretroviral therapy, you do not need to repeat the LP 6 months later if clinically they're doing better and if their RPR is heading in the right direction. So we've answered the question, how do I treat this patient? Should I use steroids? And do I need to use additional doses of benzathine penicillin G? And we've also answered the question, do I need to repeat CSF examinations? And for most patients, you do not need to repeat them. Should the patient be started on DoxyPEP? And the answer is this patient, remember, has gotten several STIs. And keep in mind that, and now is coming in with syphilis. He is one of the groups where DoxyPEP is recommended, men who have sex with men or transgender women. Those are the only 2 groups where DoxyPEP is recommended. and he's had multiple STIs in the last year, year and a half. So it makes sense that DoxyPEP could be beneficial for this patient. Now, I just remind you for DoxyPEP, there have been several studies. The recommendation now is only to use it in MSM or transgender women. The data in cisgender women do not support its use for now. There are additional studies that are being done, and so we need to wait for additional studies. But for now, cisgender women should not be getting DoxyPEP, but everybody else can get DoxyPEP. And remember, DoxyPEP, it's essentially 200 milligrams of doxycycline taken within 72 hours of an exposure. 200 milligrams of doxycycline taken within 72 hours of an exposure. And the question becomes, okay, there are things we don't know about DoxyPEP. What happens to resistance to STI organisms and to others? For example, for syphilis, does it increase the risk of doxycycline resistance in syphilis? Nobody knows the answer. There was one in vitro study that was done recently by the group in Seattle, and it showed that it's unlikely to develop, but it's possible. Unlikely, but possible, but it's an in vitro model. In clinical practice, we don't know. Of course, it can impact the microbiome, and we know it does, but what that means for the patient is unclear, and we're probably not going to know what it means for many, 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 many years. But what does it do to syphilis serologies? If I pop the occasional doxycycline and I get infected, now remember, DoxyPEP prevents you from getting 70 to 80% of cases of syphilis, right? The incidence of syphilis drops about 70 to 80% if you're taking DoxyPEP consistently. But 20 to 30% of people will get syphilis when they're taking DoxyPEP. What will it do to the clinical manifestations? What will it do to the serologies? I've had many people call me and say, I have a patient on DoxyPEP and they're coming in with an ulcer and it's not herpes, but their titers didn't go up. Their RPR titers didn't go up. Could that be the doxycycline? And the answer is yes, it could be. And so keep in mind that when somebody's taking DoxyPEP, you should anticipate that serologies may not behave in the same way as when they're not taking DoxyPEP. And so keep that in mind. If you see somebody whose titers didn't go up, but there's clinical evidence of syphilis, treat them because they're on DoxyPEP. And so keep those things in mind with DoxyPEP. I think DoxyPEP is a very good intervention for the right patients. I think our patient is probably the right patient to take DoxyPEP. And these are the current recommendations for DoxyPEP. And these have been published in MMWR, I think about 4 weeks ago. So they are all summarized for you on this slide. At the initial visit, what you should do. At the follow-up visit, what you should do. It's a beautiful summary. If you want to learn more, DoxyPEP and MMWR in Google, and the first thing that comes up are these beautiful guidelines. You can also just take these slides and read them. Now, that was our first patient. Our patient was treated, did well, excellent. Now we have our second patient, a 26-year-old woman with HIV, CD4 count 900, HIV RNA undetectable, also on Biktarvy, is diagnosed with secondary syphilis when she presents with a rash and hair loss. Her pre-treatment RPR is 1 to 64, and she's treated appropriately with 2.4 million units of benzathine penicillin G on June 1st, 2022. 3 months later, her titer is still 1 to 64. 6 months later, her titer is still 1 to 64. 9 months later, her titer is still 1 to 64. A year later, almost a year later, her titer is actually a little more than a year later. Her titer is 1 to 32. So the titer has not gone up, but it has not come down fourfold. What do you do with titers that don't do what you want them to do, right? And so remember with titers, you're looking for that fourfold decline. You're going from 1 to 32 to 1 to 8. You're going from 1 to 256 to 1 to 64. You're looking for a 2 dilution or fourfold decline. That's the goal of treatment. And if the titers go up fourfold, then it's either reinfection or treatment failure. So what do you do when titers don't do what you want them to do? And about 20 to 25% of patients, their titers don't do what you want them to do. Don't get frustrated. The first thing is, remember one thing that will make your frustration dissipate, completely disappear. 1906. These antibodies, the RPR titers, right? These non-treponemal antibodies were discovered in 1906, and we're still using them in 2024. It's kind of amazing that they work as well as they do. They're not perfect. This is what people wore in 1906. This is what they drove in 1906. And we're still using these darn titers to help us manage patients with syphilis in 2024. So don't get frustrated. They're not perfect titers. And so I'm going to tell you how to manage these titers when they don't do what you want them to do. Keep in mind, after treatment, the RPR titers can go down appropriately. Excellent. You don't have to worry about it. Once they go down fourfold, you're done. It doesn't matter how high they still are. If they came down fourfold and you don't think the patient got reinfected, call it a day. Don't keep, oh my God, the titer is still high. What should I do? Just leave it be. If the patient's asymptomatic and they didn't get reinfected, you're good to go. But sometimes the titers may not come down fourfold like our patient. And that's called serological non-response. If the titers don't come down fourfold, they may increase by 4 dilutions if they go up, and that's called serological failure. And that can be due to reinfection or treatment failure. Now, I know some of you use the term serofast, and in the old days, before penicillin, serofast meant that when you treated a patient, their RPR titers did not become negative. If the RPR titers did not become negative in the old days, you had bad outcomes. You had the potential for a higher risk for bad outcomes. But in the modern era, in the antibiotic era, we don't need the RPR titer to become non-reactive. If it goes down fourfold, we're okay. So the two possibilities, the bad possibilities when you treat somebody, are serological non-response, the RPR titer doesn't go down fourfold, or serological failure, the RPR titer goes up fourfold. So now I'm going to teach you what you need to know in both of these situations. This algorithm will guide you. It's not perfect, but it's going to guide you with every patient, and it's very reasonable. Here we go. Are you ready? So now, for patients whose titers don't come down fourfold, like our patient, at 1 year, their titer hadn't come down fourfold. So the first thing, are there any neurological, ocular, or otic signs or symptoms? That's the first thing. Are you dealing with neurosyphilis, ocular signs? If there are, then manage the patient accordingly. If they have headache, photophobia, do a lumbar puncture. If they have ocular manifestations, send them to an ophthalmologist immediately to be evaluated. But if they don't, did you wait long enough for the titers to come down? Now, our patient living with HIV, early syphilis, we waited for a year. With patients with HIV, the recommendation is to wait for up to 2 years. As long as the patient didn't get reinfected and the patient is asymptomatic otherwise, you can wait for up to 2 years for all stages of syphilis. For patients that are not HIV infected, it's wait for 1 year for early syphilis or 2 years for late syphilis. So for persons with HIV, 2 years for all stages of syphilis. For patients who are not HIV infected, 1 year for early syphilis, 2 years for late. So if with our patient, if you don't think they got reinfected and they're asymptomatic, otherwise asymptomatic, then you don't have to do anything. You can just keep following the patient. So did you wait long enough for the titers to decline? If not, keep following. Did the patient get reinfected, or is the patient pregnant? If they got reinfected, just treat them. And you say, how do I know if they got reinfected? By history. You're going to have to ask them, and you're going to have to trust their responses. Is the patient pregnant? If they're pregnant, I don't take any risks. I just retreat them again. But if they're not pregnant, if you don't think they got reinfected, if you waited long enough for the titers to decline, is the titer high, 1 to 64 or higher? If it's high, still high, consider a CSF examination. In one study, there was one study that was done that showed that 30% of patients could have CSF abnormalities if you did a lumbar puncture. Consider it. There are no data to suggest that it's going to change outcomes, but usually if the titer is high, I will do a CSF examination. If the CSF examination is abnormal, I treat them for neurosyphilis. If it's normal, you can either keep following the titers or you can give them one more dose of treatment, one more course of therapy. Since you've waited for more than a year, you can give 3 doses of benzathine penicillin G. Or the other option is to just keep following them. If they didn't get reinfected, if they're not having any signs or symptoms, keep following them. That's what I do. But if you're worried, you can give them one more dose, one more course of therapy. After that one more course of therapy, stop. If their titers don't come down, leave it be. It's done. You've done all you can. Don't keep giving them treatment. If they're asymptomatic and they haven't gotten reinfected, call it their new baseline and move forward. What about the titers that go up fourfold? What should you do? The first thing I do is I sit down with the patient and I don't say, hey, did you have sex since the last time I saw you? Your titers have gone up fourfold. I just look at the patient and say, Mr. Smith, since the last time I saw you, your titers have gone up fourfold. There are 2 possibilities. The first possibility is you could have gotten reinfected. Remember, oral sex can give you syphilis. And if that's the case, easy peasy. I can just go ahead and treat you again and we're done. But if you didn't get reinfected, if you've not had any exposure since the last time I saw you, then there's a serious possibility that we need to make sure is not happening. The organism can come back in the central nervous system even without causing any symptoms. And in order to find out whether it's come back, we need to do a lumbar puncture, and I explain what a lumbar puncture is. And then I look at Mr. Smith and I say, Mr. Smith, what is the more likely scenario? Could you have gotten reinfected, or should we do a lumbar puncture? In the last 5 years, I've had 6 people tell me I could not have gotten reinfected, doc. Let's look for neurosyphilis. And 5 out of the 6 had abnormalities on their CSF. So minimizing social desirability bias allows you to get at the right answer. You want the patient to tell you the truth. And by giving them the options, you're much less likely to get social desirability bias, where a patient doesn't want to lie to you, but they're going to tell you what they think you want to hear, which is the socially desirable answer. So avoid that by giving them the options and letting them choose which option is the right option. So the first thing you do when the titers go up, are there any neurological, ocular, or otic signs and symptoms? Did you repeat the titers 2 weeks later? If you do an exam and the patient has no signs and symptoms, repeat the titers 2 weeks later. In about 20 to 30% of patients, the titers will miraculously come down and you won't need to do anything at all. So always repeat the titers 2 weeks later, 3 weeks later, whatever. Are the titers still elevated? If no, you're done. If the titers are still elevated, then you should consider a CSF examination. And I'll start by saying there are no data comparing outcomes for patients who have a CSF versus 3 doses of benzathine penicillin G. We just don't know. And the CDC recommends that the patient undergo a CSF examination if they were not reinfected and if their titers are persistently elevated. So now these algorithms allow you to manage the patients appropriately, whether the titers did not come down or whether the titers went back up. The take-home point from all of this, ladies and gentlemen, is never try to interpret syphilis serological titers in the absence of a history. Don't ever try to interpret them because you need a history to be able to understand what's going on. With our patient, we waited for a year. She's living with HIV, so we should wait for 2 years. We made sure that she didn't get reinfected, and we made sure that she had no neurological signs or symptoms. Excellent. We can sit back and say, see you in a few months, and we'll repeat the titer, and we can continue to follow for up to 2 years. If the patient had been not living with HIV, and we waited for a year and treated them for early syphilis, and the titer didn't come down, did they get reinfected? If they didn't, their titer was 1 to 16, so it's not very high. They had no neurological signs or symptoms. I'll just follow. But if you happen to be somebody who's anxious, oh my God, do I just follow? Then you can treat them with 3 doses of benzathine penicillin G. But then if the titers don't come down after that, leave it be. You do 1 additional treatment course if you really want to, and then otherwise leave it be. Ladies and gentlemen, if you have a question about any STI, the CDC funds a beautiful service called the NNPTC Consultation Network. You go online, it's free, you put in your question, and within minutes to hours, somebody's going to answer your question for you. If you want to learn more about STIs, go to the wonderful National STD Curriculum. There are fabulous podcasts. I did a podcast on serologies. We did a podcast on ocular syphilis, neurosyphilis, mycoplasma genitalium, whatever floats your fancy, it's over there. It's a wonderful resource, and it's all for free. This is my email address. If you have questions on syphilis, take it down, send me an email. I'm always happy to answer it. And now let's do post-question test number 1. We have to do it. Meredith, we have to do it. Let's see how they do. All right, get ready for this one. If you get it wrong, I'm going to haunt your dreams. Here we go. 32-year-old cisgender asymptomatic man, and he has a reactive treponemal EIA, a non-reactive RPR, and a reactive TPPA. So 2 different reactive treponemal antibodies. Two. Which of the following is not possible? Which one is not likely? Early syphilis, false positive treponemal antibody, treated syphilis, or old untreated syphilis? Which of the following is unlikely to be the right answer for this patient? I don't know. Can you see the little Meredith, do you see the vote? I don't see the vote either. Okay, here we go. You don't have to vote. I'm going to give you the answer. And the answer is there are 2 different treponemal antibody tests that are positive. So this is not a false positive treponemal antibody. All the others are possible. Treated syphilis is possible. Old untreated syphilis is possible. Early syphilis is possible. And prozone reaction is possible. But the treponemal antibody being a false positive treponemal antibody is not likely because there are 2 different treponemal antibodies. Then we have our friend, a 40-year-old man with HIV, diagnosed with early syphilis, treated. His titers didn't come down at 1 year. 1 year, the titer didn't come down. What's the best approach? Continue to monitor the titers up to 2 years. CSF exam, treat with a single dose, treat with 3 doses. What is the best answer? And the best answer, I would say, and now you would say too, if you believe what I told you. Most people don't believe what I tell them. That's fine. But if you believe what I told you, then because you only wait a year, somebody who has HIV, you should wait an extra year. They didn't get reinfected. They had no neurological, ocular, or otic signs or symptoms. You can just keep following their titers without doing anything. And so that's my correct answer for this question. Thank you so much. I really appreciate it. I'm going to stop sharing my slides. I hope you found this useful. You can email me anytime with questions. Meredith, I leave it in your great hands. Thank you.
Yeah, bravo. Thank you so much. I agree with all the participants. What a truly exceptional, outstanding presentation.
Thank you so
many
much.
questions answered. Syphilis, we truly have so many questions all the time, and that's, I think, why you love it and I love it. Lots to discuss. So with that, we did see so many questions come in. I'm going to try to answer the ones that are probably more general, or pose the ones that are more generalizable, and not specific cases quite so much. But lots of really great questions. So let's just jump right in. So how long with early primary syphilis will the RPR be non-reactive? This is in the case of a false negative. Days or weeks? And then I added on to that question, when would you suggest repeating the RPR if initially negative?
Yeah, that's a great question. So the answer is you can start seeing antibodies being produced at around 7 days. But there are some people, remember, everything is on a normal distribution. And there are some people in the tails of the normal distribution where it takes weeks for these antibodies to develop. So let's say you see a patient and the RPR is non-reactive and they have an ulcer, right? You got the RPR, it's non-reactive, go ahead and treat them. And then you can repeat the RPR titer maybe a few weeks later. But remember, if you treat somebody whose RPR titers are non-reactive, even if they have syphilis, there are 2 possibilities. You treat them, and if you check a few weeks later, their titer may go up, but you don't know what the baseline is. So you have to sort of play it by ear. The other possibility is if you treat them very early in early syphilis, their RPR titer will not go up. They'll never go up. And that's okay. It doesn't mean you made a mistake, that the patient didn't have syphilis. It just means that you treated them early enough that you abrogated the antibody production, the RPR antibodies being produced. So keep in mind that when you see a patient, if the RPR titer is not there, you can repeat them in a few weeks. Usually 1 to 2 weeks later, the titers come back if you don't treat them. If you treat them, and I would encourage you to treat them if you suspect they have early syphilis, because you don't want them to leave and transmit the infection to others. Treat them, but it can go either way. The titers may still go up after treatment, or the titers may remain non-reactive.
Okay, so in a similar question, or kind of in the same spirit of that,
Yes.
in terms of infectious after receiving treatment, how long would a patient be considered to be infectious? And maybe you just want to give a general sense. There might be a little bit of misunderstanding because there's a question about kind of the titers declining. Can you just tell us when patients with syphilis are considered to be infectious?
Don't link it to titers. So infectiousness, don't link it to titers. Ignore the titers. Once you've treated somebody appropriately for early syphilis, remember, to transmit sexually, it's early syphilis, primary and secondary mainly. Later stages, late stages, they do not transmit sexually. Vertical transmission from mother to fetus, all stages can transmit. But sexual transmission, I usually tell my patients, don't have sex for about 7 days after I treat you. 7 days is usually my answer. There are data, human data, to suggest that after about 72 hours, there are no more viable treponemes in the lesions, in primary lesions. But to be safe, I usually say 7 days, no sex.
Thank you for that. And if someone has a rash and a physician or provider accidentally touches the rash, should they be concerned?
You've got to have micro trauma to get infected. So if you rub on that rash really hard, maybe. But otherwise, if you shake the hand, if you touch the rash, you're going to be fine, because you need micro trauma to allow the organism to go inside your body. Okay.
And then there's a question of clinics considering switching to the reverse screening algorithm. Can you just, the advantages, kind of pros and cons of reverse versus traditional?
So the most likely reason why people want to convert is because the reverse sequence algorithm can be automated for the first part of it. So treponemal antibodies can be done in an automatic way, automated. And so you don't need as many techs to do RPRs. But now there are automated RPRs too. So you could go either way. But usually it has to do with cost. For example, Hopkins moved to the reverse sequence algorithm because they test 2,000 to 3,000 blood samples every month. And when they moved to automated, from those 3,000 samples, they only have about 150 that come back positive with an RPR, with a treponemal antibody. And so the other 1,900 are negative. It's much easier to automate it and then do the small number that come back positive with an RPR than starting with 3,000 RPRs that have to be hand done. So when they switch to the reverse sequence algorithm, they cut their costs by 75%. So it's a cost-cutting measure. I like the reverse sequence algorithm because let's say you have a patient that's coming in and you do an RPR, like our first patient. Remember, they had the lesion in the mouth, and let's say we didn't use the reverse sequence, we used the RPR. The RPR is going to come back non-reactive. And you're going to say, my patient doesn't have syphilis. But now you guys know the 3 rules. And you know that the possibilities with a non-reactive RPR are early primary syphilis, old treated syphilis, old untreated syphilis, prozone reaction, and no syphilis, right? It could be any of these 5. The reverse sequence algorithm will, by giving you a positive treponemal antibody test, tell you, watch out, this could be syphilis. Whereas the traditional algorithm, you get a negative RPR, you have to use your brain to figure out what that negative RPR is. So the reverse sequence algorithm, in my opinion, gives you a lot more information that you can sort of use to figure out what you want to do with the patient.
Agree with you. Okay, kind of similar. Isn't it the case that in some instances, for example, after treatment of early syphilis, that some treponemal tests can revert back to non-reactive?
You got it. Somebody caught me. There is an exception to that rule. Once positive, always positive. If you treat somebody very early in the course of syphilis and you treat them appropriately, after 5 to 10 years, in about 20% of these patients, the treponemal test can become non-reactive. The reason why I don't mention this is because it makes my life miserable. I don't consider it because there's no way to consider it in any meaningful way. And so I would say you're right. You caught me. You called me out. But it's really hard to do anything with that information. Just keep in mind that if you treat somebody really early on with syphilis, 10 years later, their treponemal antibodies can become negative. But then you're stuck. What do? It becomes tough to manage.
Okay.
Thank you for that. You caught me.
I like this question. What are the can't miss parts of your history and physical exam when assessing for manifestations of neurosyphilis?
Honestly, the history is the most important. For me, the history is where it's all at, right? And the physical exam, usually if they're walking in, they're walking, talking, moving their brain, and not complaining of light bothering their eyes, and they're talking to you, usually you're not going to miss anything major. But the history is really important. So I always ask the questions that I showed you on that slide, I ask them in 20 seconds or less, because patients usually are saying, no, 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 no. Usually the one where they stop at is headaches, right? Headaches is so non-specific. And so then I go back and say, okay, tell me about your headaches. And they say, well, I've had these same headaches for the last 20 years. Excellent. It's not neurosyphilis. And so you have to spend a little bit of time. If they say, yes, I've had, blurry vision. Okay, let's talk a little bit more about the blurry vision. Is this new? No, not really. My diabetes, when it gets out of control, I get blurry vision. Not ocular syphilis. Right? So you have to sort of go back to the positives and try to dig deeper to figure out if it could be due to syphilis or if it's due to something unrelated to syphilis.
Got it. Thank you. Okay. How should a provider, there were kind of a few questions like this. This is kind of an example of what they are. How should a provider and patient interpret an RPR test that may fluctuate back to one to one? Either if there's been an exposure or not, but just kind of going from non-reactive to one, is that exceptionally meaningful or not really?
So that's a great question. And the answer is, it depends on the history of the patient, right? So if the patient says, listen,
We
I've
have a
not had
theme
sex,
here.
it's a theme. That's why I ended with that slide. If the patient says, listen, I've not had sex, I'm with my partner. My partner is monogamous. We're cool. I wouldn't think twice about an RPR that goes from non-reactive to 1 to 1 to 1 to 2. These low titers, who knows what they need? And so I wouldn't worry. But if they say, yeah, I've had unprotected, you know what? In those cases, the pretest probability for reinfection, when it's moderate to high, give them 2.4 million units of benzathine penicillin G. And if the pretest probability for reinfection is low, don't worry about it. Low titers, the same thing when you treat somebody, let's say you treat somebody for unknown duration and their RPR titer is 1 to 4, right? 1 to 4. And you give them the 3 doses of benzathine penicillin G and their titer doesn't budge. Just leave it be. If they didn't get reinfected, just leave it be. Those low-level titers may never budge. So don't get anxious. Don't get upset. Give them the 3 doses of benzathine penicillin G. You've done good work. And then just keep following them. As long as the titer doesn't go up fourfold, you don't have to worry about it.
Okay. And kind of similarly for those patients who fall out of care and you may not be able to see, does their titer decline? Does it go back up? If they come back in and it's exactly where it was before, is it sort of the same kind of Q&A that you go through the
Yeah. I
same
always
song?
ask it. It's a great question because you know what? Let's say I come in and my titer is 1 to 16 and you treat me and, and then I don't see you for another 8 months. And I come back in and my titer is 1 to 4. You don't know what happened to that titer when you didn't see me, right? It could have gone from 1 to 16 to 1 to 1. And then I could have been reinfected and it went up to 1 to 4 when you saw me. You don't know what happens in the periods of time between titers. That's why it's always incumbent upon us as clinicians to sit down with the patient and say, hey, tell me, what happened since the last time I saw you? Tell me more, and if you've had sex, great, no problem. We can work with that. It's not a big deal. But you want honest answers, and trying to establish a mutually respectful and trusting relationship with the patient is the most important thing. Because if you do, patients will tell you anything. My patients often will tell me anything. And I love that.
And everything, anything and everything.
And everything. And I love it. I'm like, I'm delighted because I feel like they trust me and we can deal with any issue that comes up. So it's always about the history. If you have a suspicion that it could be a reinfection, nobody's going to come after you if you give them a dose of 2.4 million units of benzodiazepine.
Absolutely, about the trust, non-judgmental. Yes. I love it. Okay. This is an easy one, I think. So if somebody's in the middle of their 3 injections for late latent syphilis treatment, and they're lost to follow-up in between, when do you restart the series? At what point?
10 to 13 days if they're not pregnant. So you can go 10 to 13 days between doses if they're not pregnant. If they're pregnant, 9 days. So if they come on day 10, start over again. If they're not pregnant, if they come on day 10, in Baltimore, we use 10 days for non-pregnant patients. Other jurisdictions use 13 days. It's fine. I don't think it matters. Pick the one you like. And then if they come the day after that top number, start the series over again.
Great. Okay, and then there were a couple of questions about if somebody comes in, you're concerned for neurosyphilis, maybe you're seeing them in the clinic and about to send them to the ER. Should you give them that dose of BPG 2.4 million units IM, or does that interfere with your CSF analysis?
Listen, if you can give them 2.4 million, if you're worried that they're going to run away, right? Giving them 2.4 million units of benzathine penicillin G is not going to harm. And it's not going to change the parameters of the CSF examination within the first week or so after you give it. So if you give it and then a week later somebody does a CSF and it's negative, you treated them, you're done. But usually pleocytosis, elevated white cell count, is going to be there even after treatment for weeks and weeks and weeks. And so even if you give them 2.4 million units of benzathine penicillin G, it will not impact a CSF exam that you do in the next few days. But really, you don't want to wait a few days. If you suspect neurosyphilis, you want to do it right away. But I've had patients where I say, are you going to go to the ED? Yeah, and I'm going to go home and then I'll go to the ED. And in those cases, I give them a 2.4 million unit of benzathine penicillin G, and I say you really, really, really need to go to the ED, and you hope for the best. But it's not going to affect the CSF parameters if it's done within a week or so.
Perfect. Okay. This is a treatment question. It says with the shortage of BPG, which we kind of said is not such an issue, the supply chains have improved now. But can Doxy be used in the treatment of latent syphilis? So maybe just in patients who are living with HIV. So just kind of a review of alternative regimens briefly.
Beautiful. So absolutely. If you have somebody, anybody, it doesn't matter who they are, except if they're pregnant, non-pregnant adults. It doesn't matter if they are living with HIV or not. For early syphilis, you can treat with 14 days of oral Doxy. And for late latent, you can treat with 28 days of oral Doxy. It works just fine. Ideally, you want to do penicillin, but if you can't, for whatever reason, you can do Doxy, no problem, but you can't do it in pregnant patients. In pregnant patients, the only option is benzathine penicillin G. That's the only option you have. You can't use anything else. The ASTDA is going to release a position statement on pregnancy, and there is no other option for pregnancy. Benzathine penicillin G or bust. That's it.
Okay. I think we're going to make this the last question since we're coming up on the quarter hour. And this is maybe a little more philosophical, and you touched on it, but just how concerned should we be about antibiotic resistance in this new era of DoxyPEP?
No, I think we should keep antibiotic resistance in the back of our minds. But honestly, where I think antibiotic resistance is going to be a problem is not with, I'm going to be careful here. In the right patient that I think would benefit from DoxyPEP, like our first patient, right? Our first patient is a really good patient for DoxyPEP. Multiple STIs, MSM, it's just, he's the right patient for DoxyPEP. In the right patient, I think DoxyPEP is very useful. I think the risks of complications from STIs are higher than the risks of resistance from DoxyPEP. So whenever you're thinking about whether you want to use DoxyPEP or not, think about the risks of DoxyPEP and the risks of an STI in that patient. If you think that the risk of the STI in that patient is high, I would use DoxyPEP. I think we should use it. The data from San Francisco clinic, where they've used DoxyPEP fairly aggressively, are absolutely riveting. The CROI, it showed at least a 50 decline in incident syphilis, 50% decline. Those are incredible numbers. And so what I would say is, yes, there are some unanswered questions with DoxyPEP, but in general, I have no problem using DoxyPEP in the right patient.
And I think we can keep in mind that several studies have shown the best predictor for a new STI is a history of an STI. And that was part of the criteria for the DoxyPEP study, was a history of an STI, a bacterial STI in the past 12 months. So we can apply that to our own patient population, I think, and really focus and do more good than harm, hopefully. So, okay, well, that was outstanding. I will say the participants kept me very busy with all these questions coming in.
Thank you. Thank you,
So
participants.
we
Thank you, Dr.
appreciate,
Clement. You were
yeah,
fabulous.
well, we very much appreciate the audience participation and this phenomenal lecture. I think that maybe the last 20 comments that have come in are really all just praise for Dr. Ghanem. So, anyway, I do want to round out by just saying that evaluations and information on how to claim CME and other certificates of participation will be emailed by 5 p.m. Pacific time tomorrow. So please remember to do your evaluations. And then just a quick update on some upcoming, really other exciting webinars and other talks. So we've got the Going Antiviral podcast, the latest episode with Rafi Landovitz and what he's excited about in terms of PrEP and HIV prevention. We've got management of substance use disorder in pregnant people with HIV. That is going to be on August 6th. Overview of data presented at the 2024 International AIDS Conference on August 20th with Dr. Klein and Dr. Sachs. And then diagnosis, treatment, and complications of diabetes in people with HIV. That will be on August 27th. And finally, a talk on OIs, September 10th, 2024. And last but not least, CROI in 2025. So exciting, San Francisco, California. That's March 9th through 12th. All right, thank you, everyone. Thanks, Dr. Ghanem. Thanks for the participants, and thanks to IAS-USA.
Thank you, IAS. Thanks, everybody. Happy summer.
All right.
Thank you, Dr. Clement. Great to see you.
Yeah, thank you. Great to see you also.
Bye, everyone.